are about to start our case, she is a 18 months old child with bilateral severe to profound hearing loss, and we are planning the right ear. Ideally, bilateral implantation should be done, but because there is high cost involved in the purchase of the implant as well as the surgical procedure, and the government is only funding 1 year, so we have selected the right ear to be implanted. Now, whenever you want to decide on which ear to be implanted, there are two factors which should be taken into consideration. First is what is the anatomy of the inner ear, which we come to know by the CT as well as by the MRI. And second point is how much hearing loss the child is having. So the ear which is having a profound hearing loss is usually selected for the implantation, while the opposite ear we can give a hearing aid, so the patient can have an advantage of bimodal hearing. And if the hearing loss is same on the both sides, then usually the right ear is selected because of dexterity and easy manipulation of the device by the patient. So now I am giving local injection, which is a standard 2% xylocaine with adrenaline. So being a child, you have to limit the use of 2% xylocaine and adrenaline. Try to use it as minimum as you can. So the postoral area you can see. The postoral area where you are going to give the incision is infiltrated.
Good morning all. I am myself Dr. Rajeshri, Professor and Head ENT Department of GMC Jalgaon. I welcome you all on behalf of our department. With the due support of our Dean Sir, we have started our CME, we have organized it, and it's our mentor, which she needs no introduction, Dr. Kanchan Tadke Ma'am. She is from GMC Nagpur. She has accepted and she is our mentor for the CI surgery. This is her second surgery in Jalgaon. So we conducted the CME to help and to so that our student can learn having this academic event for you all. On behalf of department, I welcome you all. And now, as she is a surgeon in true heart, she didn't wasted her time and started the CME and has shown all the infiltration. Now I'll hand over Head Department of Anaesthesia, Amit Hivarkar sir, to just tell a short gist about how the child is and what the anesthesia is. Handing over to Hivarkar sir.
Very good morning to all. I am Dr. Amit Hivarkar. I am Professor and Head of the Department of Anaesthesia at GMC Jalgaon. I welcome you all to this CME, and we are delighted that under the guidance of our respected Dean Sir, Dr. Girish Thakur Sir, we have got the opportunity to give anesthesia to such high-end procedures. Actually, our role begins with the patient coming to us for the MRI because the cochlear implant was planned well in advance. So it was good that we had a first-hand experience of how the patient is, what are the comorbidities associated with her, and the first successful plan of doing an MRI at this center only with inhalational agent helped us in deciding the further plan. As we all know, cochlear implant demands some specific anesthesia requirements. It's a pediatric case. There's a lack of communication, so we have to take the parents into confidence. We have to see to it that the patient is well optimized. And these are the days where it's winter, so the child generally catches some sort of cold or cough, which again can delay the procedure. So we have already taken the care that this patient does not have such problem. And of course, the plan of anesthesia is general anesthesia. with all the due care. As you can see here, we have the advanced anesthesia workstation, the Allied Neptune 1, with all the parameters and facility for end-tidal carbon dioxide monitoring, temperature monitoring, inhalational agent monitoring, and the standard monitors like NIBP, pulse oximeter, and cardioscope. We have a defibrillator also available in case we have some issue with the cardiac rhythm of this patient. So by and large, we are going to coordinate this procedure with the surgical requirements, and we have initiated all the things well. We'll be letting you know if at all something is to be told with regards to anesthesia and as the CME proceeds. So thank you once again to the Department of ENT for giving us an opportunity to be a part of this CME. Thank you.
Thank you, sir. Thanks a lot. Without anesthesia, I think we won't be able to operate in a single case, as it is a child and we require general anesthesia. Thank you, sir. With no hustle and bustle, our anesthesia team is very cooperative. I think we don't have any case postponement regarding high risk and all that. Here, the anesthesia team is very strong and supportive. They support us and technically very strong also. So now I hand over mic to Dr. Akshay to say further enlighten us about the case and the proceedings.
In this case, we would be using the nerve monitor. So, Dr. Lalit Rane is our assistant professor. He has been setting up the nerve electrodes. He will be giving a brief as to all electrodes needs to be fixed and the way it needs to be fixed.
Handing over to Dr. Lalit, our lecturer, ENT.
Good morning, everyone. We are using nerve monitor today. I have placed 4 leads over chestal area. First over manubrium. For facial nerve stimulation, first lead will be placed over the orbiculis oculi muscle over the supraorbital region. Second lead will be placed over the orbiculis oris muscle over the upper lead region of the same side. Simulator 1 is placed over the ground as a electrode over the chestal area over the manubrium. And the fourth lead simulator 1 return is just 1 centimeter below the manubrium level. Nerve stimulator is used for facial nerve stimulation during cochlear implant surgery.
We'll proceed further. Dr. Kanchan Tadke Ma'am will be giving a brief about the CT MRI images. So be patient first, as it is very important that we should read the radiology before proceeding to the surgery. As always, you know that this congenital sensory neuron hearing loss is syndromic and non-syndromic and usually associated with syndrome. So they have multiple anomalies and there are different types of anomalies. So ma'am will be giving. I'll hand over mic to Kanchan Tadke Ma'am for further.
So whenever we read HRCT of the temporal bone, the axial cuts are the most commonly preferred one. So as I scroll from top to bottom, here you can see this is the squamous part of the temporal bone, the pinna here, and some part of the tragus seen. So now you can see the petrous bone, the air cells which are visible on the right side. Because we are operating the right side, I would focus more on the right side. So the first structure which you see in the petrous bone from superior to inferior, this is the dome of the superior semicircular canal. And as we go down, then you can see this is the ampulated end of the superior semicircular canal and the non-ampulated end. This is the crus commune here, and this is the start of the posterior semicircular canal. So the superior and posterior will be joining to form the crus commune. Now, as you can see the nice nematization of the temporal bone in the superior part. So as we go down, here you can see the vestibule appearing. So this is the vestibule, this is the lateral semicircular canal. So this is the lateral semicircular canal, giving a signet ring appearance which is classically described. And here you can see the internal auditory meatus coming like this. And the anteriorly the facial nerve, the start of the intralabyrinthine part of the facial nerve, and a small nerve going to the vestibule, the vestibular nerve, superior vestibular nerve. So as we go down, you can see this ice cream cone appearance of the malleus head of the malleus and the body of the incus. This is the epitympanum, this is additus to antrum, and this is the mastoid antrum and the mastoid air cells. Okay, and here what you can see is the modulus. This is called as the mid-modular view. Here you can see the basal turn of the cochlea here. This is the vestibule. So now as you go further down, we can see this complete basal turn here, the middle and the apical turn. This is described as the stack of points. So the basal, middle and the apical turn. And this is the cochlear aqueduct here, which can be seen, the jugular bulb here. So it is important to see the position of the jugular bulb also. Sometimes it may be high riding coming in your view of the round window. And second thing which you should see is whether the bulb is dehiscent or there is a good bone over it. Now here there is a good bone, though it's little high riding. And here you can see the malleus handle and the incus long process. This part is the pyramid. This conical structure here is the pyramid. So lateral to this will be the facial recess here, and medial to the pyramid will be the sinus tympani. And this is the facial nerve. Now facial nerve is very important. First we saw that the anatomy of the cochlea is normal. Second is what is the condition of the facial nerve. So if I want to trace my facial nerve from above, so we have seen this intralabyrinthine part going anteriorly giving the GSPN, and then posteriorly this is the proximal part of the horizontal or the tympanic segment of the facial nerve. So as I go down, this I think the scan should be very good with thinnest 0.5 mm. So we now can see this horizontal part of the facial nerve. If you can appreciate this going here just below the lateral semicircular canal, and as we trace it down, this is our vertical segment here. It is taking a second turn and going down the vertical segment of the facial nerve, and here you can see this is the vertical segment. So we have this narrow space here, and you see that there is a lot of bone in this. This is the area from where we are going to go reach out to the round window. This is the round window. Okay, so we have a very small space here from where we have to do the posterior tympanotomy. Okay, so let's start our case.